Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, students, and welcome to Crazy Nurse RN Hub, where learning becomes a tradition. My name is Crisel Merdocanes, nurse educator, teaching medical and surgical nursing. As continuation to our topic on gas exchange and respiratory function, we have the management of patients with upper respiratory tract disorders. Upper respiratory tract disorders are those that involve the nose, paranasal sinuses, pharynx, larynx, trachea, or bronchi. Many of these conditions are relatively minor and their effects are limited to mild and temporary discomfort and inconvenience for the patient. However, others are acute, severe, and life-threatening and may require permanent alterations in breathing and speaking. So as an overview to the anatomy or to the structures of your respiratory function, we have this image. Now we have your upper airway infection. It is also known as upper respiratory infections or your URI. It is the most common cause of illness and affects most people on occasion. Some infections are acute with symptoms that last several days. Others are chronic with symptoms that may last for weeks or months or recur. It includes rhinitis, viral rhinitis or the common cold. We also have your rhinosinusitis or formerly known as your sinusitis, pharyngitis. We also have tonsillitis and adenoiditis. Also, peritonsillar abscess and laryngitis. For rhinitis, it is a group of disorders characterized by inflammation and irritation of the mucous membranes of the nose. It may be acute or chronic, non-allergic or allergic. And it is classified as seasonal rhinitis and perennial rhinitis. When we say seasonal rhinitis, it occurs during pollen seasons. For perennial rhinitis, it occurs throughout the year. For the etiologies or the cause of this disease or disorder, first, we have changes in temperature or humidity. Others, it can be caused by infection, also by age, and systemic disease. And also the use of over-the-counter and prescribed nasal decongestants. And lastly, presence of foreign bodies. Now let's proceed to the clinical manifestations. Rhinorrhea. We also have the nasal congestion, nasal discharge, sneezing, pruritus of the nose, roof of the mouth, throat, eyes, and ears. By the way, your rhinorrhea means this is an excessive nasal discharge, also known as your runny nose. For the medical management, it is symptomatic, okay? That means we treat the symptoms. Pharmacologic therapy. So we use antihistamines, corticosteroid nasal sprays, oral decongestants, and also we use antimicrobial agents or antibiotics for bacterial infection. For the nursing management, it is focused on educating patients about self-care. We have to instruct them to avoid and reduce exposure to allergens and irritants. Also, we have to control the environment at home and work. Health teachings on medication administration, hand hygiene technique, and emphasizing the importance of vaccination. Now let's proceed to the viral rhinitis, or the common cold. It is the most frequent viral infection in the general population. It is self-limiting and caused by a virus. When we say self-limiting, our body heals by itself, okay? So it depends on our immune system on how long will it recover and go back to the normal state, okay? So we don't use any antibiotics here. Remember, if the cause is viral, antibiotics are ineffective. The term cold refers to an infectious, acute inflammation of the mucous membranes of the nasal cavity, characterized by nasal congestion, rhinorrhea or runny nose, sneezing, sore throat, and general malaise. For the clinical manifestations, we have low-grade fever. The patient can experience nasal congestion, rhinorrhea or runny nose, nasal discharge, halitosis or bad breath, sneezing, tearing of eyes, of watery eyes, sore throat, and general malaise. So these are the clinical manifestations of your common cold or viral rhinitis. And lastly, we also have chills. The patient might experience chills. Now let's proceed to the medical management. NSAIDs, or your non-steroidal anti-inflammatory drugs, together with decongestants, expectorants, antimicrobial agents, and antihistamines are being administered to patients having viral rhinitis or common cold. And also, we treat the symptoms here. So we provide adequate fluid intake, we instruct the patient to rest, prevention of chilling, and use of expectorants. We also have a condition called rhinitis medicamentosa. It is also known as rebound rhinitis. It is caused by overuse of topical nasal decongestants. Okay, so that means there is an over usage, okay, of this medication, especially if it is used in a long period of time. Okay, so the intended effect of that medication is being reversed. We also have the nursing management, okay, and it is focused on educating patients about self-care. So we have here hand hygiene measures, cough etiquette, health teachings on how to treat symptoms. Now let's proceed to rhinosinusitis. It is formerly called sinusitis, and it is an inflammation of the paranasal sinuses and nasal cavities, and can be caused by a bacterial or viral infection. And it is classified into acute, which is less than 4 weeks, subacute, 4 to 12 weeks, and chronic, more than 12 weeks. Okay. So for acute rhinosinusitis, it is further classified into acute bacterial rhinosinusitis, or your AVRS, and acute viral rhinosinusitis, or your AVRS. For the clinical manifestations of your acute bacterial rhinosinusitis, we have purulent nasal discharge, facial pain, pressure, fullness. So your facial pain, fullness manifestation may involve the anterior face or the periorbital region. And also, the patient may report cloudy, colored nasal discharge congestion, blockage of stuffiness, localized or diffuse headache. And also, patient may report high fever of 39 degrees Celsius and higher. Symptoms occur 10 days or more after initial upper respiratory symptoms. For the clinical manifestations of your acute viral rhinosinusitis, we have it is similar to AVRS or acute bacterial rhinosinusitis, except there is no high fever and there is an absence of facial pain, pressure, fullness, and the symptoms occur fewer than 10 days post-onset of upper respiratory symptoms, and it does not worsen. Since the causation, so the causation or it is caused by the viral infection, the body heals itself because it's self-limiting. So this condition does not worsen, or the patient condition will not be deteriorated. Next we have your assessment and diagnostic findings. So first, we have to obtain the history and of course perform physical assessment. Trans-illumination as well. We perform trans-illumination. Also, CT scan is indicated for complications, and flexible endoscopic culture techniques, and swabbing of sinuses in order to determine if the causation is viral or bacterial. So, regarding the trans-illumination of the affected area, it may reveal a decrease in the transmission of light with rhinosinusitis. So there is a decreased transmission of light. So that would indicate that the patient has rhinosinusitis. For the complications, we have your osteomyelitis, mucocele or the cyst of the paranasal sinuses. Also, we have your intracranial complications such as your cavernous sinus thrombosis, meningitis, brain abscess, ischemic brain infarction, and severe orbital cellulitis. So for your thrombosis of the cavernous sinus, it is an infection leading to blood clot caused by the complication of an infection in the paranasal or central phased sinuses. So as you can see in this picture, we have an inflamed cavernous sinus. So the signs and symptoms of thrombosis of cavernous sinus, we have fatigue, seizure, vomiting, impaired vision, boil on the face, drooping eyelids, high temperature, sinusitis, an infection in the skull, severe pain or numbness in the face, infection in eyes, redness, swelling, or irritation around the eyes. For the medical management, we have the goal. So the goal in managing this disorder is to shrink the nasal mucosa, relieving pain, and treat infections. So this goal is directed in managing the rhinosinusitis. We also have to administer intranasal lavage. This is indicated for viral rhinosinusitis. For decongestants and antihistamines, these are also indicated for viral infection. For your intranasal corticosteroids to decrease the inflammation, so it is used both in viral and bacterial infection. So we administer also 5 to 7 days course of antibiotics for bacterial infection. So resistance might occur for viral infection. That means if you know that this is viral, you have to, that the infection is caused by a virus. So it's a viral infection. So you would not give antibiotics because it might create resistance on the antimicrobial or on the antibiotic. For the nursing management, we have here educating patients about self-care, such as if the patient has complications, it requires immediate follow-up. Okay. Also, there should be we should also recommend humidification of air, warm compress to relieve pain. Also, we have to instruct the patient to avoid swimming, diving, air travel, and tobacco smoking. Okay, so this could aggravate the condition and could infect. Okay, it could further infect the sinus. Okay. We also have your health teaching on the use of medications. And of course, we have to watch out for complications as well. For chronic rhinosinusitis, it is accompanied by nasal polyps, and it is diagnosed when the patient has experienced 12 weeks or longer of 2 or more of the following symptoms: mucopurulent drainage, nasal obstruction, facial pain, pressure, fullness, and hyposmia, which means decreased sense of smell. For the recurrent acute rhinosinusitis, it is diagnosed when 4 or more episodes of acute bacterial rhinosinusitis occur per year, with no signs or symptoms of rhinosinusitis between the episodes. So, use of antibiotics with recurrent acute rhinosinusitis is given or is even higher than chronic rhinosinusitis. For the clinical manifestations, we have impaired mucociliary clearance and ventilation, cough. The patient might experience chronic hoarseness of voice, chronic headache in periorbital area. The patient might have periorbital edema, facial pain. Patient might experience snoring, okay? Sore throat, adenoidal hypertrophy, fatigue or nasal congestion, and decreased smell, taste, and sense of fullness in the ears. For the assessment and diagnostic findings, we should obtain a comprehensive history and physical assessment. So the imaging studies used are X-ray, sinoscopy, ultrasound, CT scanning, and MRI. For the complications, we have your severe orbital cellulitis, subperiosteal abscess, cavernous sinus thrombosis, meningitis, encephalitis, ischemic infarction. So these are the complications related to the disorder. Now let's proceed to the medical management. Over-the-counter nasal saline sprays. We also administer analgesics because of the pain, decongestants, antibiotics for bacterial infection, corticosteroids nasal spray. Okay, this is to lessen the inflammation. And of course, we administer leukotriene inhibitors. This is a respiratory drug. Now let's go to your surgical management. So we have a surgical procedure known as FESS, or your functional endoscopic sinus surgery. It is a minimally invasive technique in which sinus air cells and sinus ostia are opened under direct visualization. So it is computer-assisted or computer-guided surgery for precision. So we have here steps. So a balloon catheter is inserted into the inflamed sinus. Then the balloon is inflated to expand the sinus opening. Then the saline is sprayed into the inflamed sinus to flush out the pus and mucus. The system is removed, leaving the sinuses open. When the sinus balloon is inflamed, it restructures and widens the wall of the sinus passageway while maintaining the integrity of the sinus lining. Now let's proceed to the nursing management. So it is focused on educating patients about self-care. So we instruct the patient to blow nose gently and use tissue to remove nasal drainage. Also, we have to instruct them to increase fluid intake for hydration and of course to mobilize the secretions. Also, we have to apply local heat, okay? Because it creates a soothing effect, elevating the head of the bed, health teachings on medications, and follow-up care. Now let's proceed to pharyngitis. So it is classified as to acute or chronic. Acute pharyngitis means it is a sudden painful inflammation of the pharynx, the back of the throat that includes posterior third of the tongue, soft palate, and tonsils. We also have viral pharyngitis. It spreads easily in the droplets of coughs and sneezes of unclean hands. Okay, so this is caused by a viral infection. We also have the Group A BETA-HEMOLYTIC Streptococcus or the GABHS. It is commonly referred to as Group A Streptococcus gas or streptococcal pharyngitis. It warrants the use of antibiotic treatment. So this type of pharyngitis is considered bacterial. So we need to administer antibiotics. And gas causes acute pharyngitis. So we call that as strep throat. Okay? It's very common that we hear strep throat. Now we have your clinical manifestations. So it's a fiery red pharyngeal membrane and tonsils upon visualization. Lymphoid follicles, enlarged and tender cervical lymph nodes. There is no presence of cough, okay? Fever, malaise, sore throat. So these are the clinical manifestations of your pharyngitis. Now for the assessment and diagnostic findings, first we have to identify either it's viral or bacterial infection. Because when we say it's viral, it's self-limiting, okay? It will just cure itself, okay? Depending on the immune system status of the patient. When we say bacterial, there is an initiation of antibiotics as to the gas infection. We also perform rapid antigen detection testing or your RADT, okay? So it uses swab that collect specimen from the posterior pharynx and tonsil. RADT is reported to be 90% to 95% sensitive, thus facilitating earlier treatment and earlier symptom improvement and reduction in pathogen transmission. Now let's proceed to the medical management. For viral infection, it's basically a supportive measure, okay? For bacterial infection, we administer antimicrobial agents such as antibiotics. For the nutritional therapy, so we provide our patients with liquid or soft diet, cool beverages, warm liquids, and flavored frozen food because these give soothing effect. We also have the pharmacologic therapy. So the drug of choice here is penicillin, which is an antibiotic. We also have your cephalosporin and macrolides if allergic to penicillin. And also we give analgesics for pain. For the nursing management, we have symptomatic management. That means we treat the symptoms. So we instruct our patient bed rest, hygiene practices, saline gargle or throat irrigation. Also, we provide ice collar, okay, to relieve the pain, and not sharing eating utensils, okay, especially for bacterial infection. This is to prevent cross-contamination to others. Replace toothbrush with a new one, okay, so especially for bacterial infection. Now let's proceed to chronic pharyngitis. It is a persistent inflammation of the pharynx. So we have three types of chronic pharyngitis. So first, we have your hypertrophic. It is characterized by general thickening and congestion of the pharyngeal mucous membrane. Also atrophic, probably a late stage of the first type. The membrane is thin, whitish, glistening, and at times wrinkled. Lastly, we have the chronic granular. It is characterized by numerous swollen lymph follicles on the pharyngeal wall. So these are the three types of your chronic pharyngitis. For the clinical manifestations, we have constant sense of irritation or fullness in the throat, intermittent post-nasal drip, and of course, patient might experience sore throat. For the medical management, it focuses on relieving the symptoms. So we manage the symptoms. So symptomatic therapy, avoiding exposure to irritants, correcting any upper respiratory, gastrointestinal, or cardiac condition. For the surgical management, of course, we perform tonsillectomy if it's really severe. And we have your pharmacologic therapy. So we administer nasal sprays and antihistamines and decongestant. For the nursing management, it is focused on educating patients about self-care. So it recommends avoidance of alcohol, tobacco, secondhand smoke, and of course, exposure to cold or environmental or occupational pollutants. So we also minimize exposure to pollutants, wear disposable face masks, okay? Plenty of fluids, okay, to keep the patient hydrated. Gargling with warm saline solution because it gives a soothing effect. Also, your saline solution has an antibacterial property. Lozenges, okay? So we also administer lozenges, okay? Tonsillitis. So it is the inflammation of tonsils, two oval-shaped pads of tissue at the back of the throat. So we have tonsillitis. So tonsillitis, it is the inflammation of the tonsils, two oval-shaped pads of tissue at the back of the throat. So we have two types. Acute tonsillitis, it can be confused with pharyngitis. Also, we have your chronic tonsillitis. It is less common and may be mistaken for other disorders such as allergy, asthma, and rhinosinusitis. We also have your adenoiditis. It is an inflammation of the adenoids caused by infection, frequently accompanied by acute tonsillitis. GABHS, or your group A, beta-hemolytic streptococcus, it is the most common bacterial pathogen for adenoiditis. Epstein-Barr virus, it is a most common viral pathogen. For the clinical manifestations for tonsillitis, we have sore throat, fever, snoring, and difficulty swallowing. For adenoiditis, we have mouth breathing, so it's a foul-smelling breath, earache, draining ears, frequent head colds, bronchitis, and voice impairment or a noisy respiration. For the assessment and diagnostic findings, we need to have a thorough physical exam and history. Specimen culture to identify the causative agent and also to classify whether it is a bacteria or a virus. Also, we conduct audiometric assessment because this can affect our hearing abilities. Medical management for this disorder is supportive measures. Okay, so we have increased fluid intake, we administer analgesic for pain, salt water gargle for soothing effect and antibacterial properties. Also, we advise our patient to rest. We also have your antibiotics for bacterial infection. So the first line is always penicillin. Okay, then we have your cephalosporins. Surgical management. So the patient, if the condition is too severe, so the patient might undergo tonsillectomy or adenoidectomy. So there is a removal of tonsils and removal of adenoids. For the nursing management, of course, we have to provide post-operative care. So that includes continuous monitoring. We also have to position our patient in prone, head turns to side. Okay, this is to provide, or this is to drain the excess secretions from the patient in order to prevent aspiration. Okay, so we have to position the patient prone and the head turns to side. Also, we have to maintain an oral airway until gag reflex returns. And also, we have to apply ice color. Remember, your ice promotes vasoconstriction. So that means it prevents further bleeding. We also have to focus our nursing management on educating patient about self-care, understanding the signs and symptoms of hemorrhage, health teaching about pain medications, and we also need to advise or to educate our patient to take the full course of antibiotics as prescribed, warm saline solution, soft diet, okay, maintain good hydration, and milk and milk products are avoided. Okay, so we avoid this milk and milk products post-operatively because it may be restricted. They make removal of the mucus more difficult for some patients. So that's the reason why we have to avoid milk and milk products. For your peritonsillar abscess, it is also known as your quinsy. It is the most common suppurative complication of sore throat. It is a collection of purulent exudate between the tonsillar capsule and the surrounding tissues. For the clinical manifestations, we have severe sore throat, fever, trismus or the inability to open the mouth, drooling. So for the assessment and diagnostic findings, we have to aspirate the abscess, okay, in order to drain it. Also, we conduct intraoral or we perform intraoral ultrasound, okay, to examine the abscess on the peritonsillar structure. We also have your transcutaneous cervical ultrasound, also used to diagnose this condition. For the medical management, We administer antimicrobial agents for infection, for bacterial infection, corticosteroid therapy to lessen the inflammation. Also, we have your surgical management. So we use needle aspiration, incision, and drainage of the abscess, okay, in order to drain the abscess or purulent substance. We also perform tonsillectomy. So for the nursing management, nurse assists the surgical procedures. So we conduct pre-operative nursing care, and we also have to maintain hydration status of the patient, and of course we have to monitor the patient and to provide adequate nutrition. Now we have laryngitis. It is an inflammation of the larynx. It often occurs as a result of voice abuse or exposure to dust, chemicals, smoke, and other pollutants, or as a part of an upper respiratory infection. For the clinical manifestations, we have hoarseness. Hoarseness is a symptom where you experience a raspy, strained voice along with lowered volume. We also have aphonia. It is a complete loss of voice. And also severe cough. For the medical management, we have to advise our patient to rest his or her voice. Avoid irritants. Also, we encourage them to rest. Inhaling cool steam or an aerosol. Antibiotics. So if the cause is bacterial, so we have to give antibiotics. For the nursing management, we have to advise the patient to rest his or her voice, maintain a well humidified environment. This is to maintain the hydration of our airway. Also, we have to advise them to have an adequate fluid intake. Health teachings on prescribed medications and follow-up care for complications or any untoward signs and symptoms. Now let's apply the nursing process in the care of patient with upper airway infection. So remember, your nursing process consists of assessment, diagnosing, planning, implementing, and lastly, evaluating. So for possible nursing diagnoses, we have first is ineffective airway clearance related to excessive mucus production, secondary to retained secretions and inflammation. We can also use a nursing diagnosis of acute pain related to upper airway irritation secondary to an infection. Also, we have impaired verbal communication related to physiologic changes and upper airway irritation secondary to infection or swelling. Also, we have deficient fluid volume related to decreased fluid intake and increased fluid loss secondary to diaphoresis associated with a fever. So these are the possible nursing diagnoses that you can have for patients who have upper respiratory infections. For the possible nursing interventions, we have, of course, we need to maintain a patent airway, promote comfort. Also, we have to promote communication, encouraging fluid intake, and promote home and community-based care. Also, we have to monitor and manage potential complications.